Hey guys, welcome to my channel. This is my first medical lecture in English, so at the beginning I would like to tell you a little bit about myself. I'm an anesthesiologist and critical care physician in Belarus. I work in a maternity hospital with newborn babies and also with women. This year in May, I successfully passed the USMLE Step 1. My score was 240 and currently I'm preparing for the USMLE Step 2 and for the OET. I have some extra time, so I decided to create a video channel, medical channel here on YouTube to help you guys thrive in med school and successfully pass all your exams. Okay guys, so if you are struggling with some material and you find it difficult to understand, please feel free to write to me in the comments down below what topic you need me to cover. For example, ARDS. Okay guys, let's move on to the structure of my lectures. I will start with one or two questions on the topic that I have prepared for you, and you will see if you have any weak spots. Next, I'll jump to the material itself. While I'm talking, I can ask you some questions, you will answer them in your head, and at the end of the lecture, I will explain to you the questions that we started with. Okay, so let's begin with pulmonary embolism. Okay guys, now you can see the first question. I will read it to you. A 54-year-old man comes to the ED complaining of several hours of dyspnea and cough. He plays in an orchestra and suddenly felt shortness of breath during a concert. Before that episode, he had been healthy. He has been smoking a pack of cigarettes daily for 30 years. Pulmonary examination reveals vesicular breath sounds bilaterally with no rails. CT pulmonary angiography shows filling defects in a right lower lobe segmental pulmonary artery, but no evidence of pulmonary infarction. What of the following contributed to the lack of tissue necrosis in this patient? And you have answer choices. Okay, the first answer choice: history of smoking. 2. Intrapulmonary shunting. 3. Dead space. 4. Hypoxic vasoconstriction. 5. Sufficient bronchial artery blood flow. Okay, read carefully, think about it, and then we will proceed to the second question. This question is more for step 1. Okay, 10 more seconds. Next one. A 62-year-old man comes to the ED due to sudden onset of mild dyspnea and cough. He lives a sedentary lifestyle, smokes half pack of cigarettes daily and drinks socially. Medical history is significant for arterial hypertension, for which he takes enalapril. The patient denies recent surgeries, traumas or limb pain. BP 125/85. Heart rate 94 per minute, respiratory rate 22 per minute, temperature 37.2 degrees centigrade. The lungs are clear on auscultation. ECG shows mild sinus tachycardia. What of the following is the next step to rule out PE in this patient? 1. Leg ultrasound. 2. D-dimer. 3. Pulmonary angiography. 4. CT pulmonary angiography. 5. Transthoracic ultrasound. Okay, 30 seconds I will give you. This is more for step 2 CK. What's next step? What's next best step? Rule in, rule out. Don't worry, we will talk about it later. Just pick an answer choice. Okay, this is it. Pulmonary embolism refers to embolic occlusion of the pulmonary arterial system. Most of the cases are from thrombotic occlusion, but there are a lot of other sources of emboli. For example, gas embolism, fat embolism, septic embolism, amniotic fluid embolism, tumor embolism, parasitic embolism, and so on. Okay, next, epidemiology. Pulmonary embolism is the third most common cardiovascular cause of death after acute MI and stroke. 8–10% of patients with PE die within the first hour, in spite of correct diagnosis. 50% of patients with PE have no DVT. What does it mean? You can't rule out PE if a patient has no DVT, because this has low negative predictive value. Symptoms. What a patient can tell you. Dyspnea, 73%, so it is the most common symptom of PE. Pleuritic chest pain, 66%, cough, 37%, hemoptysis, 13%. Next, signs. Tachypnea, 70%, rales, 51%, tachycardia, 30%, S4 heart sound, 34%, increased P2, 33%, and shock if a patient has massive PE. Okay, next we will talk about risk factors, and you can read it all. I just want to stop and tell you guys about hereditary hypercoagulable states. It includes factor V Leiden mutation, deficiency of protein C, protein S, and antithrombin 3, prolonged immobilization, also distant travel, long bed rest. Next, nephrotic syndrome. A patient loses antithrombin 3, that's why he can develop thrombosis. Next, states with high estrogen. Pregnancy and exogenous estrogen use, including oral contraceptives. And please notice HIV and COVID-19. Okay guys, so on the screen you can see clinical decision rules, WELL score and revised Geneva score. Why do you need them? You will calculate total points, and this total sum will affect the strategy that you will use with this patient. Okay, here you can see the strategy that we use when we suspect pulmonary embolism. How can we rule in pulmonary embolism? So we have some concerning symptoms in the patient, and we decide to perform CT pulmonary angiography. And we can see there filling defects. The first CT scan. Where is the clot? Please find it. Where is the clot? And the answer is here. Here is the clot. So it's the left lung. This is right lung. This is descending aorta. This is ascending aorta. And here you can see left pulmonary artery, and there is a clot here. Next scan. Here you can see two clots, here and here. Okay, next one. It is in the right lung. So here is the clot. Okay, filling defects. This CT were performed with a contrast. Another case when we can rule in pulmonary embolism. A patient has deep vein thrombosis and we have strong clinical suspicion. As you can remember, only 50% of patients with pulmonary embolism has also deep vein thrombosis. But if a patient has deep vein thrombosis and we can prove it with, for example, leg ultrasound, when we have strong clinical suspicion, that allows us to conclude that the patient has pulmonary embolism. So the presence of deep vein thrombosis has high positive predictive value. And the third scenario when we can rule in pulmonary embolism is positive pulmonary angiogram. But remember that pulmonary angiography carries 0.5% of mortality rate, so it's not something that we widely use. When we can rule out pulmonary embolism, 3 scenarios. First one, low probability ventilation perfusion scan plus low clinical probability. Why do we use ventilation perfusion scans? If a patient has an allergy to a contrast, or if a hospital doesn't have CT machine or the intravenous contrast is not available, in this case we do ventilation perfusion scan. Okay, next. Negative D-dimer plus low clinical suspicion. D-dimer is detected by quantitative ELISA, and sensitivity of this test is as high as 95%. So what is 5%? 5% is false negatives. So when we have negative D-dimers and low clinical suspicion, we exclude pulmonary embolism. And the third and the last scenario is when we have negative pulmonary angiogram. One question to cheer you up, and the lesson wouldn't be so boring. Where in the lungs the clots are most commonly located? In the upper lobes, somewhere in the middle, or in the lower lobes? Please think about it. And the answer is in the lower lobes. Why? A lot of scientists think that it's because of the gravity. So in the lower lobes, there is higher perfusion. Okay, let's talk about ECG in pulmonary embolism. What you can see and notice when you take ECG. First of all, sinus tachycardia is the most common sign that you can see on ECG. Second, right bundle branch block, complete or incomplete. Why is that happening? Because right ventricle has to strain too much because the pressure in pulmonary artery is rising because of the clot that is located more distally. So right ventricle has to overcome this resistance and pump very strongly. Next thing, prominent R in V1 lead, the fourth sign. Simultaneous T-wave inversion in lead 3 and V1. It was something that I didn't know about. I didn't encounter it in other books, and it has very high sensitivity and specificity, so this sign should be memorized by you. Next sign is something that I read in each book on pulmonary embolism, is S1Q3T3 sign. It has push sensitivity and push specificity, but somehow it is in every book. Okay, about S1Q3T3 sign. It is positive in 12–50% of patients with PE, and it is present also in 12% of patients without PE. What does it tell us? Let's think about some statistics. Okay, so here is test this disease. Okay, so test positive, negative, disease present, absent. Okay. Okay, so here is test positive, disease present. It is true positive. Okay. Test negative, but disease is present. So it is false negative. Disease is absent, but the test is positive. It is false positive. Disease absent, test negative, it is true negative. Okay, so S1, Q3, T3 is positive in 50% of patients with PE. Disease is positive, test positive, so 50%. Okay, so it is true positive rate, not very high. And it is also positive in 12% of people without PE. So it is false positive rate. What can we calculate from this? Only positive predictive value, which I don't want to calculate now. I just want you to remind yourself about something. Negative predictive value. Okay, and this is sensitivity of the test, and that is specificity of the test. So this table is very important. You have to memorize it. Where is plus, minus, but it is not only a memorization. You have to understand it. What can we see on echo in a patient with PE? McConnell sign. It is akinesia in the middle third of the right ventricle. So it is not global like in right heart failure. So it is just in mid third. Let's talk briefly about the treatment options. First, anticoagulants. Please remember that they don't dissolve the existing thrombus, they do not diminish its size, they are preventing further clots from forming. We have to administer both heparin, or low molecular weight heparin, and warfarin. Why? Because warfarin takes time to work. Heparin is effective immediately. When a patient takes heparin, what do we have to monitor? APTT. In case of warfarin, we have to monitor INR. What is INR? It is standardized PT. So if a patient goes in different countries and travels a lot, it is very simple to have only INR tested. So there is no differences between laboratories. A patient can have apixaban or rivaroxaban. They are direct 10A inhibitors and they can be taken orally, so it's very comfortable for a patient. Typically, a treatment lasts 3-6 months, but it depends on the risk of further clotting. Moving on to the thrombolytics. We don't use them very widely. Why? Because there are a lot of contraindications to them. To name a few: recent head trauma, history of intracranial hemorrhage, internal bleeding, or recent surgery, pregnancy. So we use them only in two situations, mainly in two situations. First of all, in unstable patients who have a low BP and high heart rate, and also in patients who have right heart failure. Please remember that they do not improve mortality. Catheter-directed thrombolysis showed better results. Next, surgical thrombectomy. We use it when there are contraindications to thrombolytics and we have large thrombi in large arteries. IVC filter is used when there are contraindications to thrombolytics or thrombolytics don't work. Okay, so let's talk about our questions. The first question you can see on the screen. I will not read it again. The right answer is 5. Sufficient bronchial artery blood flow. Why is that? the risk of hemorrhagic infarction decreases in increased bronchial artery blood flow. Bronchial arteries receive blood from thoracic artery and intercostal arteries, and also when the lungs are healthy. So a patient doesn't have COPD, for example. In this case, the risk of hemorrhagic infarction is low. Okay, let's talk about the first answer choice. History of smoking. History of smoking only makes it worse by increasing the risk of COPD and thus tissue necrosis in pulmonary embolism. But this patient doesn't have COPD, so he's lucky. Next, intrapulmonary shunting is not even the case because it happens when there is significant lung damage and ventilation is shutting down and only perfusion is good, so there is no oxygenation of the blood in diseased parts of the lungs. Dead space. Dead space is occurring in pulmonary embolism, but it doesn't contribute to the lack of lung infarct. It occurs because there is a clot in a vessel, so perfusion is zero and ventilation is good, so the blood can't reach these oxygenated parts of lungs. Next, hypoxic vasoconstriction. It happens when there is vasoconstriction in diseased part of lungs where there is very little ventilation. And the fifth answer choice is correct. Next question. The correct answer choice is D-dimer. So after the lecture, you, I hope, followed me, and D-dimer plus low clinical suspicion rules out pulmonary embolism. Why is there low clinical suspicion? Because the patient has only mild dyspnea and his heart rate is 94. He doesn't have hemoptysis and there is no other suspicious symptoms. So we perform D-dimers. If they are negative, then we exclude PE. If D-dimer returned positive, in that case, we would do CT pulmonary angiography. Transthoracic ultrasound is not even a choice when we try to diagnose or exclude pulmonary embolism. Pulmonary angiography is not widely used. It's only used when CT pulmonary angiography is inconclusive or there is allergy to contrast and ventilation perfusion scan is unavailable or inconclusive. Leg ultrasound we also can do, but this patient denies limb pain. Okay, this is it for today. If you guys enjoyed the lecture, please subscribe to this channel, hit the like button, and see you in the next video. Bye! Hey guys, welcome to my channel. All the intravenous constraint